Hi everyone, my name is Med2Med. This video is going to be all about gastro-oesophageal reflux disease, which is really common, so very important to discuss. These notes are based on the following resources. I've been using Scott's notes, the Oxford Handbook of Clinical Medicine, and the NICE guidelines. As a disclaimer, I am a third-year medical student. This video is not intended to be a substitute for any professional medical advice, and you should always consult your doctor about any health concerns. So, the definition of gastro-oesophageal reflux disease is reflux of the stomach contents, so that's acid, with or without bile. Let's explore these two substances. First, there's gastric acid, which is refluxed in gastro-oesophageal reflux disease. Acid is a digestive fluid that is formed within the stomach lining and is highly acidic with a pH of about 1 to 3. Its role is to digest proteins. Some other cells in the stomach produce bicarbonate in order to buffer the pH of this acid and prevent damage, whilst the pancreas also secretes bicarbonate through the pancreatic duct into the duodenum to instead neutralise the acid. And then we've got bile. Bile is a substance that is produced by the liver and stored in the gallbladder. Its role is in emulsification of lipids and is sometimes present, as we've now seen, in gastro-oesophageal reflux disease. Okay, so what are the symptoms of gastro-oesophageal reflux disease? Well, there's heartburn, frequent burping, acid rash, which is acid regurgitation, water brash, which is this constant feeling of salivation within the mouth, and adenophagia, which is painful swallowing, which would be either from esophagitis or ulceration. Those are the symptoms that occur within the esophagus, but you can also get extra-esophageal symptoms. Your patients may present with these really non-specific symptoms such as nocturnal asthma, chronic cough, laryngitis, and sinusitis because the acid reflux can be so severe that it enters the larynx or the lungs. So what are the causes of this condition? Well, if there's less pressure within the esophageal sphincter, acid will be allowed to reflux. A hiatus hernia, which we'll come on to in a bit, esophageal dysmotility, obesity, too much gastric acid secretion, and delayed gastric emptying. Then the lifestyle choices like smoking and alcohol. Pregnancy can actually lead to reflux because the muscles push the food slower in order for the fetus to absorb maximum nutrients. And then there's certain drugs like tricyclics, anticholinergics, nitrates. And although controversial, a lot of people still consider Helicobacter pylori to be a cause of reflux, and you may see this written as H. pylori. We've just established that a hiatus hernia can be a cause of gastroesophageal reflux disease, but what is it? Well, there's two types. The first type is a sliding hernia, which is where the gastroesophageal junction can enter the chest and the sphincter is less effective, whereas in a rolling hernia, the junction stays in the abdomen but a part of the stomach bulges into the chest, so it's either with or without the gastroesophageal junction. This is most often found in obese women over the age of 50. The solution would be to lose weight and treat the symptoms of the disease. In some refractory cases, where symptoms still aren't managed, you may need to consider surgery. If this condition is untreated or refractory, what can happen? Well, inflammation of the esophagus can occur, so this is esophagitis. Ulcers can develop, and benign strictures, which is the result of scarring from repeated acid damage, can occur. There is an association between acid reflux and iron deficiency, and metaplasia can occur, leading to Barrett's esophagus, which we'll go over now. Metaplasia is the change in one differentiated cell to another. Then dysplasia will occur, which is the change to abnormal cells, and finally a neoplasm or new growth. This is the process that continuous acid exposure does to the esophagus. It changes from squamous cells to columnar cells, and this is what we call Barrett's esophagus. You can really see very clearly what Barrett's esophagus looks like. So you might notice the metaplasia from squamous to columnar. The healthy tissue is this lighter colour that you can see, so the squamous tissue, and the new cells being formed, the columnar tissue, is this really raw, red-looking tissue. But if it's not gastro-oesophageal reflux disease, what else could these symptoms be from? Well, it could be esophagitis from corrosives, non-steroidal anti-inflammatory usage like ibuprofen, herpes or candida. It could be duodenal or gastric ulcers, or non-ulcer dyspepsia. In some cases, it could even be esophageal spasm or even cardiac disease. If you have a patient with trouble swallowing, so that's dysphagia, or traditional drugs aren't working for them, so that's treatment refractory dyspepsia, then you would do an endoscopy. It will also be done immediately in anyone over 55 years of age with these what we call alarm symptoms, which we'll look over in a bit. After an endoscopy is done, if it is normal, then you can do a 24-hour esophageal pH monitoring and manometry, which is a test to see if the sphincter is working correctly and assesses its motility. Let's look at these alarm symptoms. If your patient has any of these, you're going to want to refer them very quickly because they could be typical signs of cancer. We can use each letters in alarms to work out what the symptoms are. There is anemia, loss of weight, anorexia, a recent onset or progressive symptoms, melena, so that's really dark tarry stools filled with blood, and hematemesis, so vomiting blood, and any difficulty swallowing, so that's dysphagia we've mentioned. What can we do for these patients? Well, typically, treatment is a combination of drugs and lifestyle changes, but surgery may be needed in those really tough cases. Let's explore what the patients can do to help themselves. Firstly, losing weight can help these symptoms, as can stopping smoking. It might be beneficial to have smaller, more regular meals and reduce hot or fizzy drinks. You need to limit alcohol consumption, and they should avoid foods like citrus fruits, tomatoes, onions, and chocolate. A reduction of caffeine is good, and in terms of sleep hygiene, they should avoid eating less than 3 hours before going to sleep, and propping themselves up in bed with many pillows is a really good supportive idea. What about what we can do for these patients? Well, there's antacids like magnesium trisilicate, alganates like the brand Gaviscon, PPIs like lansoprazole, and H2 blockers if the symptoms are really refractory. They should also avoid those drugs which may be making their symptoms worse, like anything that affects esophageal motility or those that damage the mucosa. This is one of the reasons why we prescribe PPIs for people on long-term NSAIDs. Let's look at how these drugs work a little closer. PPIs act on parietal cells. It's actually a lot simpler than it looks. So you can see a special pump inside the cell, which is what we call, more colloquially, the proton pump. You can see it's pumping out these hydrogen ions, which are also called protons, in the lumen of the stomach, and this is what's making it more acidic. So logically, if we block this pump, less hydrogen ions are going to be pumped out, and the stomach acid will decrease. H2 blockers block histamine, which you can see is what's activating the parietal cell. So it works in a similar location, but by a different method. Antacids work a bit like those pancreatic cells we've mentioned at the beginning, because they contain substances which can neutralise the acid, like calcium carbonate, which is actually just chalk, but it does a really good job at neutralising our stomach contents. Alganates like Gaviscon work in what I call a bit more physical means, by creating a physical barrier or gel that floats on top of the stomach contents and prevents this acid from rising up and irritating the esophagus. If the reflux is really resistant to treatment, we can do surgery which increases the lower esophageal sphincter pressure when at rest. There are various different types of surgery which can do this, but for now, just remember that it's increasing this sphincter pressure and stopping the acid from rising up. Okay, that was a really quick look at everything, so here's your summary. Firstly, gastro-oesophageal reflux disease is the reflux of stomach contents, that's gastric acid with or without bile. Patients may complain of heartburn, belching, acid brash, excessive saliva, and odynophagia. Over time, the metaplasia from squamous cells to columnar cells can lead to Barrett's esophagus and can potentially result in cancer. A hiatus hernia is the bulging of the stomach out of the abdomen into the chest. This can occur with or without the gastro-oesophageal junction involvement. You should always test for gastro-oesophageal reflux disease if the patient has dysphagia. You should also test if the patient has refractory symptoms, and especially if above 50 there are these alarm symptoms. You should do an endoscopy first line and then progress to pH monitoring and manometry if endoscopy is normal. The drugs that commonly treat gastro-oesophageal reflux disease are antacids, which neutralise the stomach contents, alganates, which produce this protective barrier, PPIs, which block the proton pump, and H2 blockers, which prevent histamine activation of the parietal cells. Lastly, in refractory cases, you can perform surgery to increase the pressure in the esophageal sphincter at rest. Thank you for listening.